Thank you very much.
Thank you.
We will move to the next speaker, and we have the honor to introduce the Ben Arno. Professor Ben Arno is a professor of breast medical oncology. She is a coordinator of clinical cancer genetics, University of Texas MD Anderson Cancer Center, USA. Professor Ben Arno will deliver a talk titled Update on Hereditary Breast Cancer. So please, Professor Arno.
Good morning, dear chairpersons and dear colleagues. First, I would like to thank Dr. Ghazali and the organizing committee for inviting me again to this wonderful meeting. Today, I would like to give you an update on hereditary breast cancers, and we'll try to focus on hereditary breast cancer risk factors, indications for genetic testing, implications of results for the person who is affected with cancer. Dr. Pujol, after me in this morning session, will talk about risk assessment and prevention in unaffected individuals. I will also discuss very briefly the new hereditary cancer panel testing, clinical testing, and especially in the research setting, and the meanings of incidental findings. It's a very hot and interesting topic right now in the breast cancer, hereditary, and genetics world. Just briefly to remind ourselves of the characteristics of BRCA-related breast cancers. As we know, most of these cases are at younger age onset. Most of these cases, about 70% of BRCA-related breast cancers are estrogen receptor negative. They have a high nuclear grade, and the triple negativity rate reported in the literature is anywhere between 40 to 60, even in some reports, up to 70%. And there's still a debate about the prognosis of BRCA mutation carriers and outcome of breast cancer. There was a very recent nice meta-analysis overview in Lancet that again still said that we don't know, and most probably the prognosis is about the same. So I'll give you a little bit literature information and our own studies in summary that is related to this. First, I want to start by showing you the BRCA-related characteristics that we identified in our own population in one of our publications. About 500 women with breast cancer who underwent genetic counseling and then testing at our single institution were evaluated, and we've had at that time about a 17% BRCA positivity rate. These patients were referred based on standard criteria. And not to bother you with all of the details of the paper, what I would like to show here is that this column is the non-carrier, so the BRCA negatives. This column is the BRCA1, and this one the BRCA2 mutation carriers. And when we look at the tumor characteristics, well, what is striking here is that triple negativity was, as expected and in agreement with the literature, about 14% in the non-carriers, 23% in BRCA2 mutation carriers, but 57% in BRCA1 mutation carriers. So again, close to 60% triple negativity in mutation carriers. As expected, more cases were ER negative in the BRCA group, more cases had a high grade 3 tumor in the BRCA1 positive group. What we wanted to do as an exploratory analysis is, and I will go back to this in 1 second, so the majority of the BRCA1s are triple negative, but how about the non-triple negatives? And we attempted to compare within the BRCA1 group, the triple negatives and non-triple negatives, for example, the ER positives, whether we could, based on clinical and pathologic criteria, predict that. And we obviously looked at a limited number of characteristics because this was a retrospective analysis, but there was a trend towards more higher grade in the BRCA1 group that had triple negative cancer versus non-triple negative. At this point, what we would like to see is in the literature research going on looking at gene expression analyses, and within the BRCA1 group identifying if and how the triple negatives differentiate themselves from the non-triple negatives that might also have therapeutic implications, not only for endocrine therapy, but also for PARP inhibitors and other targeted agents. Right now, they are all put in the same group and treated the same way. Since we showed, and others have shown, that there's a high triple negativity rate in BRCA1 mutation carriers, the next logical question was, should we then test all triple negative breast cancer patients for BRCA mutations? So we attempted to look at this again in our series with a more recent analysis, at which time we had more than 2,000 patients who underwent genetic counseling and testing. And we wanted to look at the characteristics of women who tested positive and see if a certain subgroup of breast cancer should be maybe offered testing preferentially. And what we've seen here is that when you look at this chart, that amongst women, for example, with triple negative breast cancer diagnosed before age 50, irrespective of family history, there was a 17.5% BRCA positivity rate. That is way above the limit, our testing limit, that we usually use in our clinical setting, which is around 10%. Any BRCA probability that is around 10%, we do offer in the clinical practice genetic testing. In this case, it was 17%. When we look at the cohort of triple negative breast cancer patients diagnosed before age 40, again, irrespective of family history of breast and or ovarian cancer, the BRCA positivity rate was 23.5%. So in that paper, we had actually recommended to test all women age less than 50, regardless family history, for BRCA. And indeed, based on this and another study, in 2011, the NCCN changed the guidelines, and now triple negative breast cancer, even without family history, is an indication for genetic evaluation and testing. What we attempted in this paper is also based on the Markov modeling to see if we would test all of the appropriate triple negative breast cancer patients and would identify individuals who have a BRCA mutation. And if we would then go on and test their first degree family members, and if the positive family members would undergo appropriate preventive surgery, such as bilateral prophylactic mastectomy and oophorectomy, we would reduce, based on the expected outcome of cancers, and this was for the statistics was for the United States, we would reduce the risk of breast cancer by 23% and ovarian cancer risk by 41%. This is, of course, prospective modeling, and it would require that we indeed test all of these individuals and reach out to their family members and test them as well, and if they do, the preventive surgeries. A lot of ifs in this scenario, of course. One question that, as I had mentioned, remains unanswered at this point is the outcome of triple negative and breast cancer positive patients. So in this study, we attempted to look at women with triple negative breast cancer whom we have seen for genetic risk assessment and counseling, and looked at their outcome in relation to their BRCA positivity. For the interest of time, I'm just summarizing the results. In our study, we did not see a difference in overall survival and disease-free survival in BRCA positive versus BRCA negative women, and all of them had triple negative breast cancer. There are, as I mentioned, a few studies that did show that BRCA, especially 1 positive patients, have a little bit inferior outcome. Many other studies didn't show it, and the Lancet meta-analysis overview did not show a difference. So right now, the understanding is that most probably the prognosis is the same. So again, going back to summarizing who should undergo genetic counseling and testing, and this is based on the, again, 2 years ago modified NCCN guidelines, is if a woman has a personal history of breast cancer diagnosed before age 50, she's a candidate, and triple negative breast cancer if diagnosed before the age 60. Is, again, even without family history, is an indication for genetic testing. If there's a family history of multiple cases of early onset breast cancer, we should look at the family history more careful and refer for genetic counseling. Ovarian cancer in the family, breast and ovarian cancer in the same patient, the probability of having a mutation is more than 80% in this person. Bilateral breast cancer, especially if the first cancer was diagnosed at a younger age, Ashkenazi Jewish heritage, a family history of male breast cancer, and again new in the 2011 NCCN guidelines is the consideration of women with ductal carcinoma in situ. if you read very carefully, the guidelines say it very smartly. It doesn't say that every single person with DCIS should be tested, but it says you can consider genetic counseling and testing for women with ductal carcinoma in situ, and doesn't give any specifics. So what we tried to do is we wanted to look into the ductal carcinoma in situ story a little bit deeper. And in one earlier on study, what we wanted to do is to see what the rate of pre-invasive lesions, especially ductal carcinoma in situ, is in BRCA positive and BRCA negative women. So in this study, we evaluated the rate of ductal carcinoma in situ adjacent to the invasive cancer in BRCA positive and negative women. And actually, unlike we thought or expected, the rate of DCIS was really similar in BRCA positive and negative patients. The literature until then had suggested, especially based on prophylactic mastectomy specimens, that the rate of DCIS in BRCA mutation carriers is actually lower, but we saw that the rate is as high as in BRCA negative patients. So this made us think, and others, that ductal carcinoma in situ does belong to the BRCA breast cancer carcinogenesis spectrum or process, and patients with this disease could be considered or evaluated for testing. Further, we wanted to then look at the characteristics of our ductal carcinoma in situ patients that we tested for BRCA and see if there were certain predictors that could help us not to test all of the DCIS patients, but identify which one we should test. In this very small study, we looked at 118 women with pure ductal carcinoma in situ without any microinvasion, who were referred for genetic counseling and testing. And as you can see, the positivity rate was pretty high. 27% of these women were found to have deleterious BRCA1 or BRCA2 mutations. And when we looked at first univariate analyses, and then we took the significant ones, and then run the multivariate logistic regression analyses, we found that women with ductal carcinoma in situ, if they had family history of ovarian cancer, and if they had the BRCA Pro score, that is a score we use, it's a model we use to identify or to calculate the BRCA probability. If that score was greater than 10%, then that woman with ductal carcinoma in situ had a higher likelihood of having a BRCA mutation. As you can see, age was not an independent factor, and family history of breast cancer was not an independent factor. So if you have a patient with or without family history of breast cancer, that really doesn't help predicting. But if you have a woman with DCIS with a family history of ovarian cancer, that's actually significant. I think the baseline, right, the bottom line here at this point is that most probably not every woman with DCIS should offer genetic counseling and testing, but we should look at the family history more carefully and see, and pick out the ideal people to be referred and genetically tested. So in the ideal world, the person who first should undergo genetic testing should be a woman with breast cancer or an affected individual. If we have, for example, this 40-year-old unaffected woman who comes in because she's concerned her sister's breast cancer at age 37, another sister at age 42, a paternal grandmother with ovarian cancer, we would tell this patient, you know what, first we should test your sister, and if your sister is positive, which in this case she's positive, then we would test the unaffected who would have a 50% risk of carrying a mutation. So we always try to start with the affected person, the person who has breast or ovarian cancer first. So just very briefly, the genetic counseling and testing, what is involved, we strongly believe that this should be a multidisciplinary approach. We receive most of our referrals from our surgeons, either for pre-surgical decision or pre-neoadjuvant chemotherapy. Patients meet with our genetic counselors for about 45 to 60 minutes to identify the family history, to draw a hopefully